Just going to wait a couple of minutes for people to join. Whilst people join us this evening, I'm just going to go through the attendee rules of engagement. This webinar is being recorded. No one can see that you're attending unless you would like to ask questions. So if you'd like anonymity during the question and answer, please tick the box to send anonymously before sending your question. You may ask the question at any point, but they'll be answered after all of the talks. If we don't get through your questions in the allocated time, which is 45 minutes to an hour for this evening, we will answer them via email after the session. This evening's agenda, we're going to start off with Dr. Antonio Rodrigues from Medfem Fertility Clinic. He's going to be talking to us about A.R.T procedures. And then we're joined by Alpesh Doshi from IVF London, and he's going to be talking about innovative embryology. And then time permitting, Dr. Valentine Akande is going to be joining us by video. He's from the Bristol Centre for Reproductive Medicine, and he'll be talking about optimizing your fertility. After which we're going to have a question and answer session, and then we'll close up for the evening. So thank you to our sponsors for this webinar, Ferring Pharmaceuticals, for helping us to bring all this information to you this evening. Okay, thank you everybody for joining us on our 6th webinar for Reproductive Health Month, South Africa 2021. My name is Saskia Williams, and I'm the founding director and CEO of IFASA. I'm proud to be bringing this Reproductive Health Month campaign and these webinars to you in association with the wonderfully talented ladies of House of Fertility Media, Lucia and Michelle, as well as the IVF Babel Africa team. We are bringing you webinars every Tuesday and Thursday evening throughout February, featuring local and international specialists and speakers. So let's get started with this evening's lineup. Our first speaker is Dr. Antonio Rodrigues. Dr. Rodrigues is a founding member and director at Medfem Fertility Clinic here in Joburg, and he'll be talking to us about assisted reproductive techniques. Over to you, Dr. Rod. Thank you so much for joining us.
Thanks, Saskia, once again for inviting me. It's always a pleasure to do these talks. And I'm going to focus really much on the procedures of IVF. Some of the slides will have quite a bit of detail. I'm not going to go into detail on every slide. I just want to share with people the different aspects of the procedures so that they have some idea of what actually goes on at the doctor's level. So the first one is IUI, and intrauterine insemination, and that can be tagged in a natural cycle where one just uses a natural cycle with ovulation triggering. It can also be that there's ovulation induction if there's a problem with ovulation in the female, and you can either use oral drugs, Femara, clomiphene, or injectable drugs such as Gonal-F, or combination drugs such as Menopur with a trigger. So the principle is we're going to get a good egg, we're going to want the environment to be fine, and then the husband will give in a sperm sample. The sperm sample will be prepared by what we call a sperm swim up, where the sperm is allowed to swim through the culture medium, and motile sperm are extracted, are actually prepared for the doctor, and he then places the sperm, very importantly, intrauterine at the top of the fundus of the uterus. It is a painless, quick procedure, and obviously the sperm then needs to swim all the way up the tube to meet the egg at the end of the tube. And that's the principles of the procedure of intrauterine insemination. If we then look at what you have to do in IVF to actually get a lot of eggs, the general principle is that if a woman has a good egg reserve, then the principle is we aim for 10 to 15 eggs in that group of patients. And this is called hyperstimulated IVF. And one then fertilizes all the eggs, and the eggs can be fertilized either by inseminating the eggs with sperm. In other words, the sperm is put on top of the egg and it'll fertilize naturally, or we can use what is known as ICSI, or intracytoplasmic sperm injection, and I'll show you a little bit more about that later. So the principle of this is we want multiple embryos. We want multiple embryos to give us a choice, and that by having the multiple embryos, the pregnancy rate per aspiration is higher. And it also then allows us the opportunity to freeze embryos. The picture on the left is a hyperstimulated ovary. Then we're getting some eggs. The next picture is blastocysts. In our particular practice, we always culture to blastocysts. That means a day 5 to 6 embryos. We generally recommend putting 1 embryo back, especially in patients who, in the younger age group. In fact, in my principle, we kind of like the idea of 1 baby at a time. It reduces the risk in the pregnancy itself. All the rest of the embryos are frozen with a rapid freezing technique for later use. I'm not going to go through the indications because I think there are going to be talks along the way. So I'm really want to focus tonight on procedures itself. One of the other ways of stimulating an ovary is where we use mild stimulations. And this is often, in our particular practice, used for low egg reserve, where the patients have a low number of follicles and eggs in previous hyperstimulated cycles. So where we thought they should have made lots of eggs and they don't. And then poor egg quality. There's no doubt in certain groups of patients, by reducing the dosage of the stimulation, you actually get less embryos at the end of the day, but better quality embryos. And there are also certain units that will do mild stimulated IVF cycles. And this is a low-cost type IVF where they aim for 1 to 2 embryos by using oral stimulations with a day 3 transfers. It's not something we do routinely in our practice, but it's definitely something that has a part to play, especially in reducing cost in IVF and giving people that cannot afford IVF an opportunity to have a baby. Again, I'm not going to go through the detail of mild stimulated cycles. It's just the principle of it. We use less stimulation in terms of the amount of drugs we use. And at the end of the day, the process of IVF is exactly the same. So what the message is for everyone is that each individual patient has a different way or a different need in terms of stimulation. So the doctor, the unit you're with, will assess you as an individual and choose the right stimulation, whether it be normal, mild, or in fact, natural cycle in certain people works absolutely wonderfully, where one aims for 1 normal egg because you cannot get more than that in the patient, or it's the only way of getting a good egg from the patient to achieve a pregnancy. So this is dependent on the person, all the results that are being assessed, and sometimes this is dependent on previous failed IVFs and the decision around what is the next step. In a natural cycle IVF, obviously you need a perfect cycle in order to take out an egg. And from then on, the IVF process is exactly the same. Instead of taking out a lot of eggs, a single egg is aspirated from the ovary. So those are just a summary of the different types of IVFs that are available. And again, the principle of it, you need to be, you trust your infertility specialist. They have techniques of understanding what's best for you, and different people think differently. And by going with them, one will achieve the best result. But from our point of view as doctors, this gives us quite a broad ability to look at a lot of things in terms of choice and change in choice if IVF didn't work. I'm just going to take you through what happens in theatre. It's good to just get a feeling of what happens in theatre itself. In our practice, the patients are put to sleep with a light general anesthetic by an anesthetist. Ultrasound scan guides the doctor in assessing the follicles. And then what happens is a little fine needle is punctures the actual vagina and it punctures the ovary. It's a 1 puncture technique, and then all the follicles in that ovary are aspirated or suctioned out. It goes into a test tube that is in a warmer, and that immediately, when that gets to a certain fullness, gets handed over through a hatch into our sterile laboratory, and that fluid then is actually assessed by the laboratory scientist. This is our particular laboratory on the other side. The laboratory scientist collects the egg, the fluid, puts it into a little culture dish, picks up the egg, and then transfers that egg into another dish. And that's what happens in terms of that primary process when we're collecting eggs. Just to mention, and this is a worry for a lot of patients, we do use the witness system, as well as we use human witness. We have a witness system. There's a little card that gets placed on this table, this platform, where all the work is done. And there's this is a dish, and there's identification by that card of every single dish or sperm containing test tube, and it's registered on a computer. So the principle of me talking about this, it's a lot of concern for some patients in terms of how do we keep control of this. If something then is wrong and it registers that there's a mismatch, there will be an immediate, please stop and check your system. Everything is recorded on a central master screen. We know exactly what's going on at any time, and that's throughout all our workstations. This technique is used, and it's very important for us to track and trace the actual process of IVF and to give people reassurance, never mind the normal quality control, and we use this witness system to do it. There's a little microchip on the dish, on the culture dish, and that is an identification tool. On the right, there's what we call a toasters type incubator, and the patient's embryos are incubated there. In our practice, that on day one we do open that, and there's assessing of fertilization, and we actually then keep our incubator closed for a full 5 days, 4 days after that, right up to the blastocyst phase, and then we assess how we've done. This is just a picture to just a little short video just to show you what ICSI is. It's as you can see through the video as it's going, there's a little sperm that's in that pipette. It's a very fine glass pipette, and that sperm is going to be injected into the egg. First, there's penetration of the egg. The sperm is still in that tube. There it goes. And then they will change the pressure, and that sperm will then be moved back into the oocyte in the cytoplasm, and that is the process of ICSI. Been around a long time, really very nice technique, and has given us the ability to really look after male fertility. Many years ago done, and it's a technique that is really good and simple really for laboratory staff that actually are well trained. In terms of assisted hatching, we do assisted hatching for thinning the outside layer of the blastocyst, and that you can see here is a little hole cut there, and that's to allow the blastocyst to hatch. Got specific reasons. We do it in our women over the age of 37 and for unexplained IVF failure, and we also do that before we biopsy embryos, so we actually prepare the embryo 1 day before. The other thing that is available to patients is pre-genetic screening or pre-genetic testing. And pre-genetic testing implies that we take some cells out of the outside layer of the embryo, and those cells are then, approximately 6 of those cells are then prepared in a special way, sent off to the genetic lab we use, and they are assessed for chromosomal abnormalities. So all of the chromosomes, the whole complement of chromosomes are assessed, and then we know that that is a normal embryo, what we call a euploid embryo. Again, I'm not going to go into the little nuances of what mosaicism is or high mosaicism. That's very specific stuff, but just to say that pre-genetic testing is available. Again, we use it for specific reasons. Patients who have had recurrent miscarriages, people who have an older age group, those are the main indications for it. And then obviously there's also pre-genetic diagnosis, and this is for people that have specific genetic problems where we can actually create a probe and look for those specific problems in the embryos. Very expensive technique, but for the people that have that problem, obviously having those type of diseases in your child becomes a very expensive exercise. So we have that ability to help them make a diagnosis and to avoid those particular genetic problems. In terms of embryo freezing is very important in modern IVF. Frozen embryo transfers are at least equivalent to fresh, if not better, if you're not choosing who you do a fresh transfer on. And the technique of freezing gets put in a very small rapid eye kit. It is then put into a liquid nitrogen rapidly at a minus 196 degrees. It is stored over any period of time, and that embryo will be available in 4 years to come. Lastly, I like to always end my talks by not talking about doctors, but by talking about our team. IVF is a team, and we're privileged in our particular practice to have a big team of everyone concerned, from nursing staff to your IVF laboratory staff and scientists, people in the clinic, and it's the team that makes the outcome right. And that's just a quick picture of our team. I know I've rapidly gone through it, but I've hoped I've given you some idea of what happens on a day-to-day basis from the time that we aspirate to the time that we freeze embryos if necessary.
Thank you, Dr. Rodrigues. I appreciate that. There is a question. There'll be more, I'm sure there'll be more coming now as well. So we're going to move on to our next speaker. Our next speaker is Alpesh Doshi. Alpesh is a consultant clinical embryologist and a co-founder of IVF London. We're very honored to have him with us this evening, and he's going to be covering innovative embryology. I see you're all lined up, ready to go.
Thank you. You can see my screen, Saskia?
Yes, perfect.
Thank you so much. Firstly, thank you so much, Saskia, for the invite, and absolutely honored to be talking today on the platform. My name is Alpesh Doshi. I'm a consultant embryologist at IVF London. I am passionate about what I do, which is clinical embryology. Dr. Rodrigues has made or paved my talk very well with a lot of the topics that I'm going to be talking about. But again, it just lands us into a very, very comfortable position about discussing everything that Dr. Rodrigues has already touched upon. So, of course, you know, the aim of any IVF clinic is to offer very bespoke care. And this is not just from a clinical perspective. As Dr. Rodrigues said, we really need to optimize stimulation based on individual patients and their needs. But also from an embryology perspective, this bespoke attention to detail is necessary so that you can optimize the care that is delivered by the laboratory to the patient. So just diving straight into it, we know what IVF is. IVF, whereby we collect the eggs through controlled stimulation of the ovaries. And of course, Dr. Rodrigues did mention that you can either have conventional stimulation or you can have mild stimulation to stimulate the ovaries to produce the eggs. The eggs are then retrieved by a very simple sedation procedure whereby a needle is inserted on either side of the vagina, and the follicles are then drained with the aid of the ultrasound, and of course, eggs are collected in that manner. On the same morning of the egg collection, the male partner produces the sperm sample. Typically, the same afternoon, the insemination procedure would be carried out, whereby if the sperm is of a healthy count and motility, we may just do conventional IVF, which is put the sperm and eggs together and let them fertilize naturally. Or if the sperm is poor in quality in any of the parameters, or if there is a severe male factor fertility issue, then ICSI is going to be performed. And again, Dr. Rodrigues showed the video for ICSI as well. And typically, this is the stage of what we call fertilization, and the embryologist would be monitoring the embryos for another 5 days till the point of blastocyst formation. And this is what I'm really going to be talking about, that what do the embryologists do over these 5-day period in order to fine-tune the selection of the embryos for transfer into the patient. So talking a bit about the ICSI as well, again, I'm going to show you pretty much the same video that you saw earlier. And here is an egg. And on the right-hand side, we have a needle that contains the sperm. And all I'm going to be doing is literally breaking the membrane of the egg and releasing the sperm straight into the middle of the egg. Now, as Dr. Rodrigues said, this has really revolutionized infertility treatment, because typically 50% or more of the cases that we see in an IVF unit these days are male factor related. So there are also some cases whereby we see absolutely no sperm in the ejaculate. And again, the technology is so much more further now, whereby we can either recommend that these men who have found to have no sperm in the ejaculate can be seen by expert urologists or doctors that deal with the male reproductive system in a lot more detail. And hence, sperm can also be retrieved straight from the testicle if there is an obstruction in the male reproductive tract. So having no sperm in the ejaculate doesn't mean that it's necessarily the end of the road for a couple to have their own genetic child. In some cases, you can still retrieve sperm directly from the testicle and use it in the procedure of ICSI to achieve fertilization. And through this technique, many hundreds and thousands of couples have had a baby purely from the retrieval of sperm that has been retrieved via a surgical technique or surgical retrieved sperm. So talking about the intricacies in the embryology lab, we know that, of course, ICSI is one of the gold standard techniques, so to speak, to achieve fertilization. But there have been some techniques that have further refined how we use sperm or how we select sperm in order to inject into the egg. So one such technique is called intracytoplasmic morphologically selected sperm injection, or IMSI. And typically, this is nothing but using very high-powered microscopes to look at the sperm in a lot more magnified detail, almost to the tune of 6,000 times magnification, so that you can see very intricate detail, such as these little vacuoles which are sitting in the head of the sperm where my cursor is pointing. So you can clearly see that there are some sperm that have no vacuoles, and there are some sperm that have got very prominent vacuoles. The aim of looking at sperm under this high magnification is to try and identify which sperm are free of these vacuoles. The theory being that sperm that are free from the vacuoles have got a more intact DNA compared to sperm with vacuoles, because they are more genetically damaged and may result in implantation failure of that embryo or even a miscarriage. So as an embryologist, our job typically is over a 5 to 6 day period once the eggs are collected. So we're not going to go into the detail of how the eggs are collected, which has already been explained. But once the eggs are collected, this is what we see. We see oocytes or eggs. This is what they look like on day 0, on the day of egg collection. Typically, after fertilizing the eggs, we see these 2 dimples sitting in the middle of the egg called pronuclei. And another 24 hours later, we see the embryo at the 2 to 4 cell stage. Another 24 hours later, we see the embryo at around 6 to 10 cells in development on day 3. And typically, after 5 days, we see what the embryo is called a blastocyst. And it must be understood that there is a nature's funnel here. Not every egg that we collect forms a blastocyst. So typically, if the patient is under 35 years of age, if we collect about 10 eggs, we should be expecting around 5 to 6 blastocysts from that patient. So you can see how the numbers come down over this 5 to 6 day time period. The aim is always to culture the embryos to the blastocyst stage so that the embryologist can clearly identify which embryos have got the implantation potential. And not only that, the embryologist will then look at the quality of the blastocyst, specifically the two types of cells that make up a blastocyst, one which is called the inner cell mass, which is this ball of cells in the middle, which forms the fetus or the baby, and this external layer of cells, which is called the trophectoderm, which results in the placenta. So these are the early embryonic cells that your embryologist is trained to grade very meticulously. So embryo transfers can either be done on day 3 or day 5. And as Dr. Rodrigues explained, typically the trend is to culture embryos to the blastocyst stage. And not only because of pregnancy rates or optimizing pregnancy rates, it's also a more physiological state to put the embryo back in the right place. So typically on day 3, your embryo may still be in the fallopian tube in its natural environment. However, at the blastocyst stage, this is when the embryo enters the uterine cavity. So it's a more physiological home for the embryo to be in at the time of embryo transfer. So apart from, as I said, the embryo selection, which is a lot more fine-tuned when you transfer a blastocyst in terms of giving you better pregnancy rates, but not only that, it helps you in only concentrating your embryo transfers on embryos that have shown a certain developmental potential. So typically, just to again give you an idea of numbers, if you had 10 eggs, if you had 8 fertilized, you may have 7 embryos on day 3, but by day 5, you may have only 5 blastocysts. So again, you have weeded out those embryos that are naturally not going to have the potential of resulting in a pregnancy. We take the decision very, very carefully with our patients on how many embryos to transfer. And again, just like the policies that Dr. Rodrigues has talked about, we also have very, very clear guidelines, and we do recommend a single embryo transfer in typically 90% of our patients. And in the UK, we use procedures like pre-implantation genetic screening or pre-genetic screening that we've talked about earlier quite frequently, so that we can use that technique as another layer of embryo selection criteria in order to prioritize which embryo to transfer to get a much higher pregnancy rate, and not only that, but a much lower miscarriage rate as well. We all know that multiple pregnancies are associated with several risk factors, such as maternal complications, a higher miscarriage rate, potentially a higher level of cesarean sections, and also premature deliveries, and these babies spending a lot longer in neonatal units, raising a higher level of requirement on the national healthcare systems as well. So we have to take this responsibility very carefully, because as a fertility clinic, it's not just having a pregnancy or a multiple pregnancy that matters. We have a responsibility of care, and it is our job as fertility experts to make sure that we're minimizing those risks and yet giving you the highest chance of a pregnancy, not necessarily by putting more embryos in, but using tools which are available to us in order to refine our embryo selection technique. Again, as Dr. Rodrigues mentioned, that embryo freezing is again very, very vivid. We also use the vitrification system or the rapid freezing technique. Typically, the survival rate of frozen embryos or vitrified embryos is around 98%. we get the same pregnancy rates, if not better, with frozen embryos compared to fresh. And frozen embryo transfer cycles are becoming very, very popular for many reasons. One of the reasons being we combine a lot of our IVF cycles with pre-genetic screening, which naturally requires the embryos to be frozen. But not only that, it also lowers the risk of any kind of complications such as ovarian hyperstimulation syndrome when the embryos are frozen. So obviously, the best results are obtained when your clinic is all comprehensively placed in the same area. So your lab and your theater and your recovery, everything is on one premises. And here where I work at IVF London, we have our lab, our recovery, our consulting rooms, everything is based on the same premises. Again, assisted hatching, this has been discussed already. Typically, we tend to use assisted hatching a bit more sparingly, of course, but in the right category of patients. And we believe that this does have value in women over the age of 40, women with a high follicle stimulating hormone or FSH level, and of course, patients who have had a previous failed IVF cycle. I also want to talk a bit about the latest innovation around certain culture media that we can use in the laboratory, which can optimize fertilization. Very rarely do we see cases whereby, despite using ICSI as a method to fertilize the eggs, the fertilization rate is still not more than 30 or 35%. In cases like this, it may be attributed that the egg has got more of an inherent problem, or potentially the sperm has a problem which fails to activate the egg, leading it to fertilize. In such cases, we can use a specific culture media which is very calcium rich, which gives a calcium kick to the egg and the sperm, making it achieve a higher rate of fertilization. And I'm not going to talk too much about it because it'll be a lot of technical jargon. Apart from that, there's been a lot of emphasis on how to select the most optimum sperm. I must say that a lot of emphasis has traditionally been on eggs and women, but we have more emerging information nowadays about sperm and some aspects that can actually be quite detrimental when it comes to IVF outcomes. And one such finding in men is called sperm DNA fragmentation, or the damage of DNA within the sperm itself. And we know through research that these kind of findings are becoming more and more of an impact for a couple in terms of achieving their dream of a successful pregnancy. And many such patients who, if they have a high DNA fragmentation level, will potentially suffer a series of miscarriages. And typically that's how they will present a problem of sperm DNA fragmentation. So we also have technology nowadays in the laboratory which can easily isolate sperm, or we can pass the semen through a zymote maze, which will easily segregate sperm of better DNA integrity and rule out sperm which have got high levels of DNA fragmentation. So sperm that has passed through this zymote maze that comes out at the other end is known to be the best quality sperm that can be used in ICSI to get a much higher fertilization rate, and not just that, but potentially a much better blastocyst formation rate and blastocyst quality as well. So there have been some studies that have shown that using the zymote, you can achieve a much better fertilization rate. You can also potentially increase positive pregnancy outcomes when zymote is used. And interestingly, also you can find more genetically healthy embryos when sperm of better DNA integrity is used. Apart from that, we also have the technology of looking at embryos under continuous monitoring, such as time-lapse imaging. And what this is nothing but an incubator which has a built-in camera. So your embryologist is inundated with the amount of information about your embryos. And I will play one such video to you, because what this equipment is doing, it's taking an image of your embryos every 15 to 20 minutes, reeling a nice video available to your embryologist on selecting the right embryo for transfer. So I must say that this has really revolutionized the way embryologists are picking the right embryos for transfer because of the amount of detail available at this stage. So here we are, we have a video of the embryo dividing from 2 cells to 4 cells to 8 cells, and soon it's going to form about 16 cells, and then it's going to form a ball of cells called a morula. And here we are, we're starting to see a blastocyst form and nicely hatching out. So the embryologist has all this information, and how do they use this information? They play the video of all your embryos side by side and look at the intricate timelines. You can see, I've just stopped this video there, but there's a clock on the right-hand side, which exactly is telling us the number of hours that the embryo is into its development. And by playing all these videos side by side, the embryologist is using their training skills to identify which embryos are developing in the right fashion and which embryos are not developing in the right fashion, hopefully prioritizing which embryo they want to transfer. So you'll see from this video that there will be 5 blastocysts that will form, but in reality, there is only 2 embryos from these 5 that do constitute the potential of resulting in a pregnancy and a baby. And we have further refined our embryo selection criteria, in this case, by applying pre-implantation genetic screening. So as Dr. Rodrigues has already talked about this, this is one of the tools that we do apply in an IVF setting, although it's considered to be an add-on at this stage. And what we do is we typically take a small biopsy of the embryo at the blastocyst stage. And once we have around 5 to 7 cells, as a result of that biopsy, we freeze the main embryo, but we send that small biopsy that we have taken to an expert genetics lab that is going to comprehensively test all the chromosomes that are involved in an embryo in order to tell us which embryos are genetically healthy, and we call these the golden embryos, and which embryos that should not be considered for transfer. So this is how we further refine our skill as embryologists in terms of which embryos to prioritize. So I'm now going to play this video of how we take a biopsy from the embryo. And here we are, we have a blastocyst there. And what I'm doing is I'm just very gently aspirating some of those cells in a pipette under a very complex microscope. Of course, everything is very highly magnified. You can't see an embryo with a naked eye, but what we're doing there, we're using a laser beam to take some of the cells away from the embryo, which is the biopsy we have just taken. So here we are, you're going to see the embryo itself in a while, but not only that, you are also going to be seeing the biopsy. So I'm just going to rewind it a bit, and you'll see that there's a small cut that is made and these cells are taken away, and this is called an embryo biopsy. And again, as previously mentioned, we also can perform certain diagnoses on the embryos, which is called pre-implantation genetic diagnosis, where you are looking for specific genetic mutations. And examples of this are cystic fibrosis, breast cancer, thalassemia, retinoblastoma, muscular dystrophy, and the list is endless. There's over 300 genetic disorders that we can test for. So IVF is not necessarily only meant for couples who are struggling to conceive to have a child, but also couples who may carry a genetic disorder which they do not want to pass on to their offspring, and hence they would need to have their embryos created and tested by a genetics lab to ensure that we are transferring an embryo which will successfully eliminate the faulty gene that they have been suffering, either through an affected pregnancy or an affected child or a previous miscarriage. So thank you so much for that, and thank you for your attention. And I will stop sharing my screen now and hand over back to Saskia.
Thank you so much, Alpesh. That was really, really interesting, and it's stuff that we don't get to see normally, and we don't get to see the procedures that you guys do in the lab. So we do really, really appreciate all your input. So we do have a few questions, and we'll run through them after we've done the video. Thank you. So up next via video, Dr. Valentine Akande covers optimizing your fertility. Dr. Akande is from the Bristol Centre for Reproductive Medicine in the UK. If the video doesn't stream well for you, we have had some technical issues last week. If it doesn't stream well for you, it will be uploaded to our YouTube channel tomorrow. And then we'll have the specialist answering your questions straight after the video.
Good day, I'm Valentine Akande, the Medical Director of the Bristol Centre for Reproductive Medicine in the United Kingdom. It's a pleasure to be speaking to you today about optimizing your fertility. I think it's important to make clear that for the vast majority of patients or people, getting pregnant is pretty routine. However, I take it that if you're listening to this webinar or this video, it means you may have experienced some difficulty getting pregnant. And for this reason, we'll be going through some things that might help you increase your prospects of getting pregnant. So again, to emphasize that for most people, getting pregnant will not be a challenge, but for a certain proportion of people it would be. And studies suggest that 1 in 6 couples seek help getting pregnant, and 1 in 4 couples experience difficulty. It is very rare that people are infertile. What happens is that some people just have some things that are reducing their chances of getting pregnant. And really, our job as fertility specialists are twofold. One is to try and establish why you might be experiencing difficulty. And the second thing is to look at things that can be done to increase your chances. So again, 1, to explore why you might be experiencing difficulty, and then 2, to provide you with specific advice as to what can be done to increase your chances. That cannot be done through this video, and for very specific advice, you might need to book an appointment with your local fertility specialist, who can then look at your situation individually and make personalized recommendations. So what I'll be talking about today is very general and not always specifically directed to you if you have a particular condition. And when we think about fertility, there are really 3 things to remember, and that is MOT. And MOT, the M starts with a man, i.e., is there good quality sperm, and the O relates to ovulation, ovarian reserve, and oocytes, i.e., are you producing eggs, are you releasing them, and do you have a good ovarian reserve? And the T relates to the fallopian tubes, or the anatomy, i.e., the tubes blocked or open because the egg travels down the fallopian tubes to meet the sperm, and then is fertilized within the tube and then implants within the womb cavity. As long as all these factors are normal, then your prospects generally are quite good. But we know that about 1 in 4 couples actually have what's known as unexplained infertility, i.e. we'll find that sperm's normal, we'll find that tubes are normal, and we'll find that they're ovulating, but they're still not getting pregnant. Now, don't worry if this is your situation, because actually the prognosis is quite good, and fertility treatment usually in these circumstances is quite effective. Having said that, we do know that helping people get pregnant, or people getting pregnant, very much is also related to physiology. What do I mean by physiology? Well, physiology very much relates to what happens normally. For example, when you're just born, you won't be expected to walk or talk immediately, nor when you're 100 years old would you be expected to run a marathon. So the same thing happens with fertility. You're most fertile when you're younger, and you become less fertile as you get older. So the best reproductive age tends to be between the ages of 18 and 45. But from the age of about 31, fertility does begin to decline, and it tends to become a bit more profound after the age of 37. This clearly doesn't mean you can't get pregnant in your late 40s, i.e. 47, even 48, but the chances are much lower when you're older. So one of the key messages to get across about boosting your fertility is really not delaying, i.e. the sooner you try, the better. And people often ask, when's the best time? And my answer is always very simple. Your chances today are better than tomorrow, and your chances yesterday are better than they are today. And that's a simple principle. It's not as if you each reach the age of 40 and then your chances just decline immediately. It's a gradual process. So generally you want to start trying sooner rather than later. And you'll recall I mentioned not too long ago about most people who are struggling not being infertile. In fact, I don't like using the word infertility, because it's very rare that people are infertile. Generally, people who are struggling have degrees of subfertility. What that means is that they have degrees of where they are struggling to get pregnant, and it can be looked at as looking at a dice. So if you've been trying for 2 years, been trying for pregnancy for 2 years, then technically by the end of that 2 years, your chances of getting pregnant each month is about 1 in 20, or 5% per month. Our job then is to try and get you to a place where we can increase your chances. For example, if you're young, 30, we can get you to a chance of about 50%, where it's a 1 in 2 chance. So the concept really is, if you're having difficulties, we have to look at it as in dice. What are your chances? Are your chances 1 in 10, 1 in 5, 1 in 20? And what can we do to increase your chances? So if you, for example, you come to us and say you've only been trying for 2 months, we'll say go away and continue trying, because actually for most cases we won't need to do anything and you get pregnant naturally. But if you've been trying for a longer period of time, 6 months or more, particularly if you're older, then you might need help. And to give you some figures, if you're 25, we would expect over 90% of couples to have got pregnant by after trying within a year, whilst if you're 40, about 50% will get pregnant within a year. So you can see that the chances change depending on your age. I mentioned as well that sperm quality does matter, and from sperm quality, the only way to assess sperm quality really is to do a sperm test. And if this reveals problems, then we normally recommend that you repeat the sperm test in 3 months, because it takes 3 months for sperm to grow, or about 90 days. So if there's a problem with sperm and you make any changes, it takes about 90 days for that to get better. And some simple things that could help include taking antioxidants. Doesn't always help, but sometimes it does. The other things you want to do is to avoid drinking, smoking, and consuming excessive amounts of alcohol. Also, the testicles are intentionally located outside the main cavity of the body in order to keep them about 1 degree cooler. So you also want to make sure that your testes are kept cool. So you want to wear loose underwear rather than tight underwear, and you want to avoid things like cycling for hundreds of miles. So many people often ask, what can I do to boost my fertility by diet? And I often explain that there's no such thing as a fertility diet, and the reason is we're all very different. Like if I prescribe a diet for you, a food you don't like, you're unlikely to comply, and therefore we won't achieve much. The key thing about fertility is to have a balanced diet, and that includes carbs, proteins, and fats. And many people try and exclude fats, but fats, in fact, for many people are important, particularly if you're underweight. So the key thing is a balanced diet, everything in moderation, and of course have fruits and vegetables. That's pretty basic, and generally, as long as you have a good diet and you're not overweight nor underweight, both being overweight or underweight can also have an adverse effect on your prospects of conceiving. The same applies to exercise. Exercise is good, but excessive exercise can also be harmful. So if you're planning to run a marathon, 10K, or something like that, that can reduce your chances of getting pregnant. Other thing to be really aware of is exposure to volatile organic compounds or noxious substances. So if you smoke, smoking actually reduces your chances of getting pregnant by about 50%, and that's whether the male or female smokes. And also being exposed or in company of people who smoke, that's even if you don't smoke yourself, also significantly reduces your chance. So you really want to be away from noxious substances. Now, one thing people always ask about is stress. I'm yet to meet anybody who's experienced fertility difficulties who doesn't experience a degree of stress, because we appreciate how important this is to you. We know how profound an effect this can have on your life, and that's why we take it seriously. But also, most fertility specialists also offer specialist treatment support or counseling for those with fertility problems. The good news, however, is that research studies show that stress doesn't tend to affect the outcome of fertility treatments unless the stress is profound, such as when it stops you having periods. Ideally, of course, you would rather avoid stress so that you're able to have intercourse at natural times and doesn't affect your other aspects of your well-being. But be rest assured that actually it doesn't appear to have a profound effect on your fertility. In terms of timing of intercourse, the key message is you want to have intercourse before ovulation. For those who notice cervical mucus or in the vagina around the time of ovulation, that's a good time to have intercourse, and you can have it every other day leading up to ovulation or every day. But once ovulation has occurred, unfortunately, by then it's too late. So for those of you who measure your temperature, once your temperature rises, it's too late. You want to make sure you've had intercourse before that. I think one other thing that's important to mention is herbal remedies. There are lots of herbal remedies purported out there on the internet to be beneficial for fertility. In fact, research studies have shown that quite a number of them are harmful. So please seek specific advice. Things like aspirin or ibuprofen, you can take them when you have a period, but don't take them at the time of ovulation because they can prevent you ovulating. If you're on any specific medication, please ask for advice. For those of you who need lubricants, there's some that are better than others, but there are no lubricants that make sperm travel faster than others. So what are some other things you can do? Well, there's one thing to get pregnant. The other thing is to maintain a pregnancy, because of course there's also the risk of miscarriage, and the risk of miscarriage also increases with advancing age. But there's evidence that taking simple preconception vitamins such as folic acid, vitamin D, and even supplements as B12, and you don't need to buy them all separately, but you can buy standard preconception vitamins from pharmacists, and that can be beneficial. If you drink alcohol, you certainly don't want to be drinking more than 4 units a week, and not in one go, and you don't want to be taking more than 2 caffeinated drinks a day. If you are a bit older or you have a poor vein reserve, then things like coenzyme Q10 might help. If you have irregular periods, it's best you seek advice. And there are ways in which we can assess your vein reserve these days, either by blood test or by undertaking ultrasound scans. So I hope you found this information helpful. The key message is, for most people, getting pregnant would be a challenge, and the way to look at fertility is also to look at it in terms of chances, i.e. like throwing a dice. The more times you try, the more likely you are to get pregnant. That applies whether you're trying naturally or with fertility treatment. Once again, thanks for listening, and I'm Valentine Akande from the Bristol Centre for Reproductive Medicine in the UK.
Great. Okay, so it's question and answer time. We've got a few minutes left for some questions. Dr. Rodrigues, can I just touch on something quickly with you before we go to the questions about stress with fertility, what your take on it is?
No, having done 22 years of research into stress, I think I don't agree with that at all. You know, there's a direct link between time urgency, perfectionism, stress. We've done the research. We see it in practice. You fix that, you manage immunological factors, you manage stuff related to endometriosis. I'm afraid, having spent the last 22 years researching it, doing the work, understanding it, if you must control stress. It is definitely an immunological suppressant. It has an effect on increased incidence of endometriosis. And I know a lot of the rest of the world don't look for endometriosis if patients don't have pain. In our practice, 90% of patients who have endometriosis don't have any other symptoms other than poor mucus and a mucus problem. So we pay a lot of attention to it. And what it does is it converts patients who would have had IVF somewhere else into patients who have a natural pregnancy. It is obviously controversial, but not in our minds.
And you can, what's the website, Dr. Rod, where they can measure their stress?
The website, so they can www.tups.co, and they can do a whole stress profile. There's 6 questionnaires. It comes up with answers. We wrote a book 21 years ago called Faster, Better, Sicker. If you look at it, it explains a lot of the factors, not in relation just to fertility, but in relation to a lot of the diseases that we believe are directly not caused by stress, but stress changes the immune system, that changes the way our bodies function, increases cortisol, noradrenaline. And at the end of the day, those things will have a profound effect at different sites in the body, depending on the person's genetics, depending on the person's predisposing factors.
Okay, great. Okay, let's whiz through a couple of questions. If we don't get your question this evening, please email them to me, saskia@ifasa.co.za, and I'll put them to the specialist and we'll answer you via the email. Okay, Dr. Rodrigues, what is IUI? When will it be used, and how many times should this be done before I move on to IVF?
Yeah, so it's very much dependent on the specific patient. Again, you know, there are strict guidelines on when you should be doing IUI and how long. I think if you make a decision to do a procedure, you need to give it at least 3 months in relation to the fact that you made the decision, because we're back to most human embryos are not normal. So you've got to give it a chance to have that normal embryo find its place in the uterus. So very patient specific, and it's very difficult to pinpoint for that particular person. But it has a place, and it must be used in that specific place. We don't use the technique where you just start with AI for 3 months or whatever, and then you go on to the next step. We prefer to be very specific on who we use IUI on.
Okay, thank you. And Alpesh, there's a question for you. First of all, they say thank you for joining us. And then if there are only 2 or 3 embryos that come out of a cycle, do you think it's necessary to take them to blastocyst, or can we put them back sooner?
A very good question. So in the fertility clinic, we do nowadays deal with a lot of women with a poor ovarian reserve or low ovarian reserve. And of course, we know for a fact that it's these women that will benefit from extended culture or culturing the embryos to the blastocyst. So one such approach that we use in patients with a low ovarian reserve is called embryo batching, whereby we will batch their embryos at the day 3 stage, maybe through a couple of cycles or 2 or 3 cycles of IVF, and then defrost those embryos and then challenge them to the blastocyst. Of course, everything is so numbers dependent in IVF. And it's a very good question that if someone has only 2 or 3 eggs, then are they good candidates for blastocyst culture? There's no right or wrong. Of course, we want to move to blastocyst in order to select the best embryo for them, and especially if we are going to combine the use of pre-genetic screening, which can at the moment is most robust at the blastocyst stage.
Okay, perfect. Thank you. Okay, then there's one, I think this is for Dr. Rod. If my husband's sperm quality is good, but he smokes, is that still a major risk? Could it also cause ectopic pregnancy and other factors that affect falling pregnant, even if I don't smoke and I'm not exposed to secondary smoke?
So a lot of the studies on smoking anyhow don't look at the specifics. They look at smoking and say, what is the outcome? I believe smoking does play a role, and you know, the fact that the sperm looks good on the tests, the general tests that are done, doesn't mean that it's behaving well when it actually gets into the egg and creates an embryo. So it's not just about a sperm fertilizing an egg. It's what happens to that sperm. The sperm has a function, and I think smoking, from a point of view of health in both females and males, actually should be avoided if possible. I say if possible because I've learned over many years that you can't tell someone to stop smoking. They got to wake up and stop smoking themselves, you know.
Agreed, they have to be ready. Okay, great. We've gone a couple of minutes over time. So I want to wrap it up. And if anybody didn't get their question answered, please email it to me, saskia@ifasa.co.za, and I'll put it to the specialist and we'll get back to you tomorrow or the next day. So thank you everybody for joining us. Thank you, Alpesh. Thank you, Dr. Rodrigues.
Pleasure.
We really do appreciate you giving your time. And thank you to everyone who watched it for joining us on our 6th webinar for Reproductive Health Month 2021. On Tuesday, we'll be online at 6 o'clock again, discussing trying to conceive with HIV. Register at reproductivehealthmonth.co.za. And also don't forget that participating SASTRE clinics are also offering 25% off your initial consultation and scan booked during February. Please check out the Reproductive Health Month website for more information and to register for that discount. Thank you, Dr. Rodrigues. Thank you, Alpesh, for giving up your time. And thank you to our sponsors, Ferring Pharmaceuticals. We do appreciate your support. Take care, everyone. Keep safe. Bye.
Bye-bye.
Bye. Thank you.
Bye-bye.